My name is Anas Younes. I'm a professor of medicine in the lymphoma service at Memorial Sloan Kettering Cancer Center in New York. We just finished a last session at the ESH meeting in Estoril in Portugal, which captured a new clinical trial designs, preclinical modeling, combination strategies using precision medicine clinical trial designs, and the use of imaging to also stratify patients for prognostic factors and then to select patients for clinical trials. So as you can see, that the session covered multiple aspects that could be clinically relevant when you design clinical trials. I'll mention the focus of my presentation, which was based on how do we move from treating patients in all-comer setting to selecting them based on biomarkers. And we talked about several biomarker strategies in diffuse large B-cell lymphomas. It's sort of like up till now, the selection biomarker strategy in patients with newly diagnosed diffuse large B-cell lymphoma used to be on what we call the cell of origin, ABC, GCB. This did not translate into any progress in advancing treatment for patients with diffuse large B-cell lymphoma. So we discussed what are the alternatives, and we talked about the new molecular classifications for diffuse large B-cell lymphoma that subdivide patients not into two wide categories, ABC and GCB, but in probably 5 molecular subsets. We also talked about how we use genetic alterations based on the DNA sequencing to guide drug development. And we mentioned the EZH2 inhibitor as a successful story, because if you capture patients with either follicular lymphoma or diffuse large B-cell lymphoma with the EZH2 mutation, they have a much higher response rate compared to those with the wild type EZH2. But that's only one example. And then we discussed how we combine drugs based on multiple biomarkers. They could be genetic or immunohistochemistry based biomarkers to develop rational design mechanism-based combination strategies. The take-home message that I think preclinical testing is still there to stay. There's not one perfect preclinical model that you can test to predict outcome in a clinical setting. Depends what question you want to ask. You can use different preclinical models, whether PDX, whether organoids, or other in vivo microinjection of different drugs. Each one adds value in its way, and so there's multiple different preclinical testing that can be used to guide therapy depending on the question you're asking. Thank you for watching us, and please join the conversation on social media, Twitter, and then also other platforms.